The next case is an interesting case. Vibhav, do you want to present?
Sure. So the next actually pair of cases that we're going to talk about is a pair of patients who have had suspicion of endocarditis on transthoracic echo, both patients with bioprosthetic aortic valves. And in this time of COVID-19, one of the as we mentioned earlier, one of the things that we're trying to avoid is procedures that will not only take up extra personal protective equipment, but also procedures that potentially could aerosolize the virus and put healthcare workers at risk. Transesophageal echo is typically what we would do in this situation to better evaluate these valves and to look for some of the complications of endocarditis. However, in this time, we're looking for other methods of trying to evaluate these valves. What do you think about using CT angiography to look at these bioprosthetic valves, particularly to look for vegetations and also look for the complications of endocarditis?
CT is actually a very good technique to use in these situations, especially with the newer generation CT scanners, which have high temporal resolution. The spatial resolution has always been good, so you're able to see small vegetations that are mobile really well. And also in looking at complications of endocarditis, abscess formation, pseudoaneurysm formation of iotomytal curtain because of these are bioprosthetic valves. And even with newer reconstruction techniques like metal artifact reduction, you can see decrease the artifact due to metal, and you can see leaflets well. And CT is already being used for hypertenuating leaflet thrombosis, and this is an additional value it will have in this situation, I think.
Yeah, so in particular, I think looking for the complications, whether it's pseudoaneurysm or abscess formation, I think CT is going to be more specific and sensitive for finding those things than TE. I think in normal times, I don't think that this is going to completely replace TE, but it can be a very complementary technique. And we're going to go through a couple of these cases right now just to give a few examples of what you can see on a CT. So this first case here, you can see there's a large vegetation attached to one of the leaflets that's flipping in and out. You can see this in the LV outflow tract and flipping up into the aorta there, very nicely imaged here on CT. On this particular case, there are no other complications such as pseudoaneurysm or abscess formation, but it helped pretty significantly for surgical planning as well, as we were able to assess the coronary arteries at the same time with this particular patient to avoid an invasive angiogram prior to their surgery. The patient did well. That bioprosthetic valve was replaced surgically, and the patient did well and is out of the hospital now. So that was one of the success stories in terms of avoiding an invasive procedure, prior to this patient going for surgery.
Yeah, the utility was really good, I think. You avoided a transesophageal echo and a cath in this patient, and you planned everything based on the CT. Going into the surgery. Yeah. And I think the patient tested COVID negative, but he came in with fevers, in the situation we are in with COVID. I think this is a unique way of using CT, CCTA for imaging these patients. And the second case you have here is another bioprosthetic valve, I think, too, right, Vibhav?
That's right. And this patient was having, this is actually an outpatient that was having recurrent bacteremia and also some TIA stroke-like symptoms. And so the question was there a thrombus or a vegetation that was on the valve? The echocardiogram prior actually didn't show really any significant vegetation or thrombus on the valve. So we weren't really expecting to see what we did end up seeing here on the CT.
Yeah, the CT here, you can visualize, I think, that there's a bioprosthetic valve, and you can see clearly that on the aortic aspect, or sinus aspect of the leaflet here, there's a clearly mobile large lesion that has a stalk attached to the leaflet, and the leaflet itself is thickened compared to the contralateral leaflet here, which is thin and much more mobile. So did this patient have any regurgitation on the transthoracic echo?
Not any significant regurgitation on the echo, and no finding of a clear-cut thrombus or vegetation on the echo. In hindsight, when we went back and looked at the echo, there may have been something there, but the image quality wasn't that great. As you can see here, we're getting such clear images and such clear pictures here on the CT that there was a high clinical suspicion, and that's what led to an additional imaging test, but these are things that can be missed on echocardiogram, and so CT can be very complementary.
Was the gradient higher on echo, on the transthoracic echo in this patient?
On this patient, actually, no. The gradient was about the same as it was prior to this being even suspected. So post-surgical gradient to the most recent gradient was about the same. So
wow.
Didn't have any findings that would even push you towards that. It was really just the bacteremia and the clinical findings of the recurrent TAAs.
Looks like you had very good images of the coronary arteries too in this patient.
Yes. Yes, that's another advantage of these 4D CTs that we get for looking at the bioprosthetic valves. You're going to be able to image the coronaries very, very well, even without the use of beta blockers or nitroglycerin to try and improve the imaging. We can still see the coronaries very well.
Looks like the surgical planning pretty much was done. You have the coronary assessment, you know where the endocarditis is, and your surgeon has all the information he needs. And even if this is a redo surgery, he knows where the heart sits behind the sternum too. So I think this is a great technique in answering so many questions in one test.
Yeah. Previously, you'd get an invasive angiogram and a CT chest all for planning purposes, and you can just get it all in one.
Yeah. Thank you for sharing this case, and we'll go to our next case.